Good afternoon, and being the last session, I will be very short and crisp. I think most of the things that I'm going to say, many people must have already covered in previous talks. And we all know that as far as the family contacts are concerned, HBV is much of a problem. For HCV, right now, routine screening is not recommended because uh, it creates unnecessary panic among the family members, and the there is not much evidence that it is that much infectious among close family contacts. So if you look in close family contacts, what could be the modes of transmission? One is vertical, that is from mother to child. We had previous sessions on this topic. The other one is horizontal. What does horizontal mean? Horizontal means that one of the family members is infected and the people who are living around that infected person get infected with hepatitis B or C somehow. And one is extrinsic or simultaneous. What does it mean? Extrinsic means, let us say there are two kids in a family and they are going to the same barber shop. From there, they acquire this infection. So, I mean, it's a kind of horizontal acquired only, not vertically acquired, but not directly from one sibling to another one. It is something from outside which has infected the family members. So, that's the three modes of transmission that you will see in the family. Now, if someone is exposed to a virus, whether he is going to have that infection, if someone is living in close proximity, in close contact with the infected person, is he going to get infected or not? The results are extremely variable. Country specific various data is available and it's quite varied. And it occurs because several factors come into play. The first is type of virus. Type of virus, what do we mean? Whether we are talking of hepatitis B, hepatitis C, or HIV. The infectivity of all these three viruses is different. I will just have a slide to just give you a glimpse of which virus is more infective and which is less infective. Among the type of virus, there are various molecular patterns within the virus. Hepatitis C, we know there are various genotypes. Hepatitis B, there are genotypes. So they have some role to play among the infectivity. The molecular virology, I already told the genotype, and also the viral load present in that infective material. The quantum of exposure. The quantum of exposure, what do we mean is whether you had just a needle prick, a small infected instrument, or a razor was used, or it was a full blood transfusion and that blood was not screened for hepatitis B and C. So we can easily understand the quantum of exposure is important. Not only this, how much virus is present in that infected material. A needle prick from someone who has got hepatitis B viral load in millions versus a needle prick from a person who has got few thousands. There will be different rates. Source is important. Saliva, needle prick, blood transfusion instrument, and obviously the host immune status. If patient has been vaccinated, previously recovered from Hep B, obviously the infection is not going to occur. If someone is too immunocompromised, it occurs easily. We know in CKD patients, even if they are not on dialysis, it may be common. So there are various subsets where this becomes important. In patients who are undergoing chemotherapy, reactivation of already hidden hepatitis B virus occurs commonly. So all these factors come into play once we talk of infection in close family contacts. So this slide I have taken from one of the websites of Ministry of Health and Family Welfare, and they have summarized it. What is the risk of needle stick transmission rates of various viruses? If you look here, the maximum risk occurs with hepatitis B if E antigen is positive, up to the tune of 30%. E antigen positivity actually is a surrogate marker for very high viral load, and maybe that's why it occurs. On the other hand, if E antigen is negative, then it is 1 to 6%. But I still think it is the amount of virus present in that infected material which matters. Hepatitis C 3 to 10%, and for HIV it is slightly low. So we don't have. I searched for a lot of literature from India, and I could gather only 3 studies which deal with this topic of how many close contacts within the family will have hepatitis B infection. This study, the lower one is from Pune, and it showed that this was way back in 1985. I mean, the vaccine status and at that time was totally different in today's era. So, I mean, we should interpret this data in during that time, the medical situation which occurred at that time. HBsAg positivity was 23%. Hepatitis B core antibody. We already have in previous sessions known that hepatitis B core antibody tells us that patient has been exposed to hepatitis B virus, was around 80%. Another study in 2005, this was from West Bengal, it showed that if someone is positive with hepatitis B virus and you test for close contacts within the family, 19% would be HBsAg positive. And if you look for hepatitis B core antibody, it would be 37%. And this one is the latest study which I would like to discuss in detail. This was published just last year from Pune, Maharashtra, and they tried to look at the risk factors and transmission dynamics of hepatitis B infection among Indian families and what can be its implications. So here they took 361 patients who were known hepatitis B patients, and they interviewed their close contacts who were living in proximity with them within a common household. They took important histories like medical procedures, tattooing, piercing, IV drug abuse, promiscuous behavior, hours of contact. Hours of contact, how many days, how many time. Let us say if you have a house worker, a maid at home, she may come at home, but she may be there for only 1 hour and then she goes back. So they classified it how many hours was in contact. Was it more than 8 hours per day, 1 to 8 hours per day, or less than 1 hour per day? Then sharing of personal hygiene products like towel, toothbrush, and sharing of utensils and sharing of bedding, they also look for. This was the demographic data. Most of the patients, as the study was from Pune, were from Maharashtra and then followed by UP. As the virology in India is, most of the patients were E antigen negative. Only we see that most of them were HBe antigen negative in this case. Now here, this is interesting. Out of all the patients, all the contacts whom they screened, not patients, only 9% were vaccinated. If you look at the overall hepatitis B surface antigen positivity rate, again it was somewhere to the tune of 9.2%. And if you look at the core antibody positivity rate, it was 32%. Now, what kind of close contacts had maximum HBsAg positivity rate? It was among the siblings, as shown here in the middle column, the siblings. The orange column is 22.9%. So the siblings of the patients are at highest risk for HBsAg positivity. Surprisingly, the spouses of the patients showed least positivity with hepatitis B surface antigen. If you look at hepatitis B core antibody positivity, that is labeled here as occult, shown by the yellow column, it was again maximum in case of parents. Now, here comes the interesting part. They also looked at what happens if someone is sharing the bed, sharing personal hygiene and common utensils. So if you look in both the groups, this is odds ratio given here. Odds means if 1.17 times more chances of having hepatitis B in close contacts as compared to if he was not in contact with that person. Sharing of bed 1.25, and the interesting part was if they are sharing common utensils, then the odds were almost double. It was 2.18%. So these were the important results from this study. Prevention part we have already talked about. Active screening of contacts for HBsAg we have to do. Vaccination of all contacts after screening. I'm not sure whether should we test for anti-HBs antibodies after full vaccination course or not. But in case of spouse and if someone is having high viral load, I think after 4 to 8 weeks of vaccination, it's a good strategy to check for anti-HBs antibodies. Now, the questionable actions are after this study, I mean, sharing of utensils, sharing of beddings and towels, what should we do? Right now, there are no guidelines. We don't prohibit using these things, but I would say we should also not encourage these practices. With this, I would like to end here and have discussion regarding this.